Assalamu alaikum. Good afternoon, everybody. This is a case that we have faced maybe 2 months ago in our hospital. He is basically 62 years old, male diabetic, hypertensive, a smoker, and he is obese. He was presented at 12 a.m. in the night with a brief episode of chest pain, which lasted like 30 minutes and associated with dizziness. 2 hours before his presentation, and now he is free of chest pain in our ED. His hemodynamic was stable, blood pressure was 140 over 82, heart rate is 65, and clinical examination was within normal. This is his ECG. As you can see, they had only early liberalization in the inferolateral leads, and there is no significant ECG changes. And this is his chest X-ray upon admission. And there is nothing of note. Troponin was negative, and patient was labeled as low-risk non-STEMI, and he was admitted for observation and for the further investigation, and he remained asymptomatic over the night. Next day, patient was reluctant to go for coronary angio, and we are discussing with him even if the possibility of CT angio, but eventually he agreed to go for coronary angiogram. While he is sitting waiting to be called for cath lab, he had severe sudden chest pain while he's sitting with his family, and he had the cardiac arrest confirmed, and CPR was started for 6 cycles, and he revived. And the blood pressure was 95 over 65. And all of us, we thought that this is most likely had the coronary artery disease, and even unfortunately didn't have the ECG, but the ECG was having some ECG changes in all the ECGs, was most likely post-cardiac arrest. But again, it suggests there is maybe some underlying coronary artery disease. So we shift him quickly for cath lab. While they are preparing the patient for draping the patient in cath lab, the ICU consultant, he called me after they did chest X-ray after CPR, which is as a routine to check their ATT and CVB line, and this is the chest X-ray, both the CPR. So what's happened? It's a flask shape and also wide mediastinum. We thought that maybe pericardial effusion plus minus also aortic dissection. And we thought maybe because patient he was in full ACS management, we thought maybe because of CPR he had some pericardial effusion. And we called for urgent echo while the patient is on the table of cath lab. And you see he had a fair LV function and circumferential pericardial effusion, which is homogeneous, and it seemed that it's already clotted as well. Through a apical approach, and we managed to pass the pigtail, and we drain around 70 cc only, and nothing more coming out. So at this stage, the cardiac surgeon was notified, and because the patient is very obese and the heart is arresting, and his maximum inotropic support at this stage. This all happened within less than 30 minutes. So shall we proceed for coronary angiogram, whether we'll go radial or femoral, to check his coronary at least, if he will survive, although he's in maximum 3 inotropic support, and blood pressure is going down and down. So just trying to see the aortic root. As you see, there is a double layering of the aorta, which most likely this is the perforation site. That's why it accumulates also in the pericardium. And there was no significant AI. So we decided to go for coronary angiogram through a left femoral, and as you see, he had no significant coronary artery disease. This is left system. Had mild disease only and some ectasia, but there is no significant coronary artery disease. This is his RCA. So aortic dissection is a life-threatening condition with very bad prognosis, and early recognition and rapid intervention is crucial to alter the prognosis. This is the first time to encounter a patient with intra-hospital aortic dissection. In my experience over the last 8 years, we have seen 6 cases of aortic dissection. All of them, they landed in our emergency with aortic dissection. And though we transferred them for cardiac surgery, but again, they have 3 of them, they died intraoperatively, and 3 died preoperatively. Screening and controlling risk factor can decrease the incidence of the disease. And this is the presentation category. This patient, maybe he belongs to category 2. And this is the type of aortic dissection. So the key message, aortic dissection can happen even intra-hospital and will not give time to manage as well. Thank you.
I like that conclusion. One line, beautiful. يلا جماعة أعطونا your input. Abdullah, your thoughts.
So, very interesting case. It's a case none of us want to see. I mean, many times when this happens, I mean, sometimes when you do your angiogram expecting it to be a normal ACS and you find your catheter is in a subintimal space and you're injecting in the arterial wall in the aorta rather than the coronaries. I mean, a couple of things I want to mention. First of all, I don't think the pigtail that was inserted, it doesn't look like it was in the pericardium. I mean, there was only one view, but I think one of the things we do with pericardiocentesis in the cath lab is when you insert the wire, you want to see it go up around the heart to be sure. That's one thing I didn't see clearly. And maybe that's why you only got 70 cc of contrast, because you showed the echo that showed a lot of fusion around the heart, right?
Yeah, so just if we can go back to the slide, it is actually rapid around the heart, but because it's clotted, because CPR for 8 cycles, and meanwhile, since he revived and they put CPB line and transfer, it takes like 20 minutes. So I think it's already clotted blood. That's why we cannot drain much. But definitely, it was ultrasound guided, and we are in the right position.
Perfect. The other thing is that when you have pericardial effusion and tamponade caused by dissection and causing the tamponade, I mean, when you put a pigtail, it's very important to be cautious in terms of the amount of blood you take, because you don't want to create an open cycle and of blood leaving the aorta and getting into the pericardium, and you're aspirating it. So that's something that's usually considered should not be done, but sometimes you have to do it if the patient is unstable. But the amount of volume you aspirate should be very cautious until you get pressure, and then you should stop. But in your case, you had to stop because it was already clotted.
Yeah, actually, we could not drain much from the pericardium.
Anyone from panelists?
Sorry, go ahead. It was a very challenging case, and as he said, nobody wants to have this case because it's really very hard when you see the patient kind of spiraling down. I think when you have the echo, it did not show significant wall motion abnormality, and it shows pericardial effusion, and it shows dissection. Of course, don't know what to do at that time, but I don't think I'll take patient to the cath lab and put a catheter in the aorta, because you may have worsening of the dissection actually. I think it's if this patient needs to go to OR immediately, and then of course with the support and then you can have the TEE done in the OR, or if you have time to do the CT scan on the way in. But I think this patient really, if the patient have tamponade with dissection, is a time is so crucial to go to OR. Unless you have ability to do endovascular treatment, and in this case you put a stent and seal it. This one probably tough because of the close to the coronary, but I think I will not do angiogram in patients who I know have dissection.
Just a very small comment and technique. Usually, if you are worried about aortic dissection, don't put a catheter. Just take an exchange wire and push it till the wire cross the aortic and go to the LV. Then you can push the catheter safely, because if you cross the wire, most likely you are in the true lumen.
Yeah, actually, this is what we did. We go gently with the guide wire and make sure we cross the aortic valve, then we go with the catheter.
فكري آخر شيء.
I think many of what I wanted to say was covered, but I just want to express that it is before we take the patient to any intervention or any procedure, if you have a patient who is agonizing chest pain, no ECG changes that is explaining this chest pain, and the troponin is not high, patient has aortic dissection until proved otherwise. You should suspect it from the beginning and then deal with it accordingly. You should not put acute coronary syndrome first in line here.
Excellent. So slight modification to the program. The next speaker.
Just may I ask a quick question?
لحظة وليد لحظة.
Sorry.
The next speaker will remove that next speaker, and I remove myself as well. So I remain with 3 speakers. قول وليد.
Thank you very much. Really, this is a case that a rare case that, and I learned a lot. Just you did a coronary angiogram. Did you leave the sheath in, or the sheath was taken out? And did you inform the surgeon? How did he do the cannulation to put the patient on cardiopulmonary support? Did he cannulate for the femoral, or how did he end up?
No, actually, this patient, he died on table. He did not give us time to go for surgery. We just called the surgeon, but because the patient was deteriorating very fastly, and after we could not drain too much, and the patient hemodynamic and stable, we just check his coronary if anything can be done for him. Meanwhile, they are ready in OR, but he did not make it. He had a BA arrest, and he died on table.
So I missed that. But any suggestion was after since you have a sheath in the femoral and a true lumen, that anybody suggested just put him on any
Mechanical support?
Yeah.
Well, maybe ECMO, it can, in this case, it can, but though the risk, we don't know where is the extension of the aortic dissection. It's clearly from echo, it's involving the ascending, but we don't know about the descending aorta as well.
Great case, Sami.
Just a last comment. I think putting any mechanical support is a contraindication in this patient with dissection. There's nothing you can do except taking him to the OR and hope for the best. Usually you don't have that time. Usually they die. It's just the reality.
Yeah, thank you very much. Excellent, Dr. Sami.